I would see that the main benefits that I've seen around staff is actually the real multidisciplinary working that the ERAS programme brings. And with the teams that are working on it, no one profession can actually do this on their own.
When you are in a financial environment that we are particularly in at the moment, where we are being asked to constantly save money and be more efficient, it does at times appear to be an impossible ask to do both. It is not impossible. ERAS is a clear example of how getting the model of care right has benefits both to the patient and to the finances of an organisation.
Historically, the financial side and the clinical side have been treated relatively separately, with financial units of care being looked at and places where savings may be made. With a multifaceted pathway like enhanced recovery, then I think close working between the finance departments and clinicians is very important.
You need your dietitians, working with your consultants, working with your anaesthetists, working with the physios, but actually the clinical teams working with the finance teams to actually model the whole thing together. So it's not just clinical teams working together, it's a very broadest multidisciplinary team, managers, finance and clinicians all working together.
Within a team where you have both managers and clinicians, there are natural underlying tensions.
The tension of finance and clinicians being on in very different places within an organisation needs to be managed very carefully. And I think what I would suggest is that the clue is to get finance and clinicians around the table together so that they are one team and not in different places. We have one agenda, which is good quality care for patients at most efficient cost, and you need clinicians and finance teams together to deliver that.
The way ERAS is delivering savings is essentially in the efficiencies in the post-operative period. So although it's enhanced recovery after surgery, there's so many elements to the pathway leading up to surgery which are as important, particularly pre-assessment and managing patient expectations.
It was a surprise that they were going to be getting me up out of bed early. I'd had my first operation before the ERAS programme came into effect, and so I was sort of, in my second operation, I was expecting to be in bed for a while, probably not leave the hospital for a week or so.
We've seen fitter, happier patients on the wards who are recovering quicker, and as a result we've seen a significant reduction in our length of stay and a reduction in complications after surgery.
Being encouraged to move around makes you realise that actually you can do it, and I also think it played a role for my family as well, because they would come in and they knew that I was improving because they could see my confidence improve and see me walking around.
When we look at applying the lessons of ERAS to areas beyond, for example, colorectal surgery, I think the first thing we have to bear in mind is that there's no one single element within ERAS which is anything more than best practice. It's just getting all of those elements of best practice, writing the best patient pathway, and getting all members of the team to be signed up to it.
We're clear that actually in the world that we're now operating in, we have to demonstrate benefits realisation. We can't just do things because they seem to be a good idea. But actually there's lots of robust evidence around ERAS to suggest that there is real benefits realisation, not in only outcomes for patients, but the financial aspect. And that has to be something that we would aspire to, as well as the clinical outcomes.
We should not be embarrassed about thinking about money. We're all responsible for the public purse, and I think we all have a responsibility to think about finances when we consider patient care.